that. And over to you, Caitlin. Thank you so much.
Okay, thank you. Just share here. Perfect. Okay. So thank you all for joining me today. So yeah, we're talking about dementia basics and behaviors today. There we go. So this is just a brief kind of introduction to the clinic that I'm coming to you from today. So GPCSO, or Geriatric Psychiatry Community Services of Ottawa. So we are a geriatric psychiatry outreach team. We provide services in English or French, and we have case managers who see members of our community that are 65 or older with complex mental health needs or dementia with challenging behaviors for which support's needed. And so our case managers provide that in-home assessment. We review the geriatric psychiatrists in our team, and we come up with a plan of care to try and address that person's needs. We have a few different groups that we run, both for older adults and their care partners. And in particular, we have those teach and carers groups, which are for caregivers of persons living with dementia. And they are open. Anyone can self-refer via our website. And then I myself am the psychogeriatric resource consultant on our team, and I'm here today to talk about dementia care. So we're going to look at defining dementia, the different types, how it typically progresses, how we can stage it, and then we're going to look at some of the different cognitive and behavioral symptoms of dementia. So dementia itself really is an umbrella term. There's lots of different diseases and disorders that all really fall under this umbrella. And so the four on the left there, Alzheimer's, frontotemporal, Lewy body, and vascular, are the most common types of dementia that we encounter. And so I'm going to talk a little bit more about each of those and what they look like. But this is just to be aware that there are lots of different types of dementia. Collectively, all dementias are referred to as major neurocognitive disorders. And in the middle here, these are 4 facts that are true of all dementias, regardless of the type. So there's always at least 2 parts of the brain actively dying. It is progressive and always changing. It is chronic, so there is no cure, and it is terminal. So dementia is something that you'll eventually die from, which I find not a lot of people know. And so for it to be a dementia diagnosis, there's changes in memory and thinking that affect a person's ability to function in their day-to-day lives. So those ADLs and IADLs are really being impacted. And so we can see here with this chart that over time, with normal aging, we'll have a bit of cognitive decline or slowing. Oops. But we can still do all the things we need to do every day. We can then have what's referred to as mild cognitive impairment, or MCI. And so with this, there's more cognitive changes than what we would expect of normal aging, but the person is still able to do all those activities of daily living. And someone might live with MCI forever, or their cognitive changes might advance into those activities of daily living now being impacted, in which case we would now diagnose as a dementia. And so this is just a nice look at some things that might be normal aging versus not normal aging. And this comes from GPCSO. And so some different things like, remembering someone's name or face, it's normal to forget that, on occasion or, in a certain situation. But when it becomes not normal aging is when people are, consistently losing track of conversations, not able to remember, familiar people to them, close family. And something really key here is that use of compensatory mechanisms. So For example, it's normal to get lost in kind of the day or the month. Might not be working anymore, but we know to look for a calendar, look at our phone, figure out what that information is. Versus someone with not normal aging or dementia, they might get lost in time, thinking it's a whole other year, time of life, and they just don't have that kind of knowledge to use a compensatory mechanism or to try and find a calendar. And so looking particularly at Alzheimer's disease, it's the most common type of dementia, accounting for about 60 to 80% of all diagnoses. And it occurs when these proteins develop in the brain and form plaques and tangles that are interfering with our cell functioning. And so the brain can't effectively do tasks related to memory, decision-making, language. And so Alzheimer's disease, we can see, typically develops in this particular pattern. So the plaques and tangles always kind of start in that same frontotemporal area, and then they spread throughout the brain over time. And so that's why we tend to see a similar progression in individuals. It's typically a very gradual progression over time. So if someone ever seems very suddenly different or unlike themselves, we want to think more delirium. Is there something acutely going on, like an infection that we need to treat, as opposed to this being a progression of the disease? With Alzheimer's disease, new details are going to be the first lost. So those memories of recent events, conversations, and then we're going to get a more gradual progression into those longer term memories, functional changes, behavioral changes. And so this is supported by the theory of retrogenesis by Reisberg, which is that process by which degenerative mechanisms in dementia reverse those of normal human development. So we can see here how with typical normal child development, we have milestones that we expect to be reached. So things like being able to sit up by around 6 months, saying a word or two by 1 year. And with Alzheimer's, we're going to lose those skills in the reverse order. So those higher level functioning skills like driving a car, holding a job, managing finances, we're going to lose those abilities first. And then as the Alzheimer's progresses, we get into those other stages, like unable to choose proper clothes, going to the bathroom by oneself. And then as we get into those very late severe stages, people lose the ability to, even eat, speak, hold their head up. And that's where we really get to the point of dementia being terminal. Vascular dementia is the second most common type of dementia, and it happens when brain cells are deprived of oxygen, and then subsequently an area of the brain starts to die. And so with vascular dementia, it can occur in more of a stepwise fashion as opposed to that regular kind of gradual progression like we see with Alzheimer's. And that's because someone might have, some kind of event like a stroke or a TIA, and they have a really steep decline in their abilities, but then they'll reach a new baseline. And then they might have another TIA, so they get another sharp decline in their abilities, and then a new baseline. And so we see it occur in more of a stepwise fashion than just a very gradual over time shift. And so vascular dementia, the risk factors are all kind of related to, healthy living. So things like having a high blood pressure, high cholesterol, smoking, not getting exercise, all increase that risk for, atherosclerosis, blood clots. So we really want to focus on active living here for prevention. Looking at Lewy body dementia, so it's a rarer type. It is more common in those with Parkinson's disease. And so with this type of dementia, we see a lot of changes in thinking, reasoning, and there's a lot of fluctuations in that. We might see even throughout the day that abilities are really changing and variable. Visual hallucinations are much more common with Lewy body dementia, though they can happen in any. And they're usually of people or animals are what folks tend to hallucinate. With Lewy body dementia, we're going to see more changes in movement, things like slowness, stiffness, rigidity, which are really indicative of that Parkinson's disease. And then we tend to see more sleep disturbances as well with this type of dementia, which is sometimes directly related to those hallucinations occurring in the nighttime and people having trouble sleeping as a result. And then frontotemporal dementia. So this one's, some of the rarer ones, and it itself is a bit of an umbrella term. There's different variants of frontotemporal dementia. And what's really unique about this one is that it's a much earlier onset than the other dementias, which tend to be diagnosed in people more 65 plus, versus frontotemporal dementia, or FTD, is usually diagnosed between ages 40 to 60. And with this one, it affects more behavior, personality, language, and movements, not so much the orientation. People tend to maintain orientation until later on in the disease. And so this one can be really tricky to diagnose because that behavioral variant of it, there's more prominent changes in personality and behavior. So this individual might be, 45, still working, has a family, and they still have that orientation. They know, their name, the date, where they are, but they're experiencing, a real loss of motivation. They're developing new obsessions, compulsions, maybe appetite changes, really geared to sweets, lacking empathy, reduced inhibition, and those troubles with executive functioning are often evident. So the ability to kind of plan, problem solve, use your judgment, make good decisions. So this one is a really difficult one to come across, but it is one of those more rare ones. It is possible to have a mixed dementia, which is when there's more than one type of dementia occurring at the same time. And so it's most common for the type to be an Alzheimer's vascular mix, but it really can be any. And when we have a mixed dementia, it's going to impact how the person progresses because we have now more areas of the brain all being impacted at the same time. And so this picture here is just kind of showing briefly how our different areas of the brain are responsible for, different things. And so we can see, with that frontotemporal dementia, it's much more the personality, judgment, movement, etc. Sorry. And so this is a really nice summary of those things that I've just been talking about. And so it comes from the National Institute on Health, and it makes a really nice handout. And so with the progression of dementia, the different types are going to look different in those earlier stages. They all have their uniqueness to them. Like Alzheimer's, people are more prone to, the wandering, repetitiveness, Lewy bodies, we see more hallucinations, versus by the time we get to the late stage of any of these dementias, they tend to look much more similar because we're getting into more of the functional changes and people all really struggling with those activities of daily living. We can use the functional assessment staging test, or the FAST, to try and stage someone's progression where they're at in the dementia journey. And what I like about the FAST is that it has the associated developmental age for the person, which can be really helpful when we're trying to, set reasonable expectations for the person. So for example, we might have someone who's living, at home alone still. They have dementia and they're struggling to, select their proper clothes and get dressed every day. And so, while they're chronologically, in their 80s, developmentally, they're looking at about a 5-year-old. And, we wouldn't really want to leave a 5-year-old home alone all day by themselves. So that leads us to, the conclusion that, mom probably shouldn't be living at home alone anymore or staying at home alone all day anymore. So the FAST is a really nice tool that we can use to try and help make that connection. And this is just a nice look at the brain with dementia. And so a real healthy brain without dementia is going to weigh about 3 pounds versus a brain with advanced Alzheimer's might only weigh 1 pound. So this is just really showing there how much volume loss and shrinkage there really is with dementia and how that's accounting for the changes that we see in the person. And so to make a diagnosis of dementia, we're going to review the person's cognition, that impact on abilities, so how they're functioning in their day-to-day life, and collateral sources are very important. So really asking, friends, family member who are close to the individual, what things they're noticing, because the person themselves might not have insight that things are changing. And so we often use the MoCA test, which is shown here, when we're assessing people's cognition. And so it's testing different areas of the brain. So looking at, that executive functioning, memory, language, orientation. There are different versions with cultural adaptations, different languages, and for different education levels. And so when we're, doing our cognitive testing, we also do a medical workup, look at the brain with a CT or an MRI. We do blood work, we do a urinalysis, and we essentially try and see, is there any other possible cause for these changes that we're seeing? And in the absence of all of that, we would go ahead and diagnose with dementia. And so coming now to symptoms of dementia, so we can really separate them based on the cognitive symptoms and the behavioral and psychological symptoms of dementia. So we're going to look first at the cognitive symptoms, which are characterized here by the 8 A's. So amnesia. So that's that memory loss beginning with the short term and eventually impacting the long terms, that really kind of classic dementia sign. And so some different examples might be, not recognizing where they are and trying to leave, not remembering where they put things. And so when we're trying to support someone with amnesia, we're really trying to make things look as familiar as possible, have a consistent routine, create that predictability for the person. Some people really benefit from a calendar or an agenda. Some people like just a little bit of info. Some people like more details. It's kind of specific to everyone, and it might change throughout the dementia journey. Lots of visual cues as well are really helpful. So labeling drawers, items, having ways finding signs to help people get where they need to go. Aphasia is the loss of ability to use language, including the ability to communicate verbally, understand, read, and or write. So we can have receptive aphasia, where the person is able to speak in foreign language, but they're not able to receive a language or understand what others are saying to them. And on the other hand, expressive aphasia, the person can understand others and what we're saying to them, but they can't express language back for themselves. They're not able to speak back to us, which can be really frustrating and definitely a source of behaviors when the person, knows what they want to say, but they just can't get it out. And so we can use communication cards depending on, how the aphasia is impacting the person. Either we can point to the cards or they can point to them to try and show us what they're looking for or needing. Using gestures is really, really helpful for people with dementia, really demonstrating what we want them to be doing versus just using our words. And when we are speaking, very slowly, clearly, giving time to respond and being mindful of that nonverbal body language and what that's saying. Agnosia is the loss of ability to recognize people, objects, or sounds. So the person might be using the TV remote as a telephone, trying to eat something that's not food, not recognizing somebody. And so it's important that we're always introducing ourselves, wearing name tags that are visible to the person, having things labeled, having those wayfinding signs so people know where, things are, like the bathroom, the dining room. Always demonstrating and offering one thing at a time so that we're not overwhelming the person with too much info. And then keeping anything that is, potentially dangerous out of reach, particularly if, our person is prone to be eating things or putting everything in their mouth. We want to be really mindful of what we're leaving out around them. Apraxia is the loss of ability to carry out purposeful movement because of that planning, sequencing being off, that ability to execute steps. And so we might see someone, layering clothing, putting the clothes on in the wrong order. So like the shirt and then the bra. And so again, really demonstrating, guiding the person, simplifying it can be helpful, as well as putting out step-by-step signs of what we're looking for. So that's shown here, the order to get dressed, the order to go to the bathroom, because we find sometimes people know that they have to use the toilet. They find their way there, but then they get stuck because of apraxia. They don't remember to pull down their pants, pull down their underwear, sit and do their business. And so having some signs like this in the bathroom really help the person through that troubling step, through that sequence that they were previously struggling with. Altered perceptions, so loss of perceptual acuity. Often people with dementia have trouble with depth perception. So for example, thinking black carpet on the floor is a hole, and so they won't want to step in it or across it. Difficulties with proprioception. So, not really knowing where our body is in relation to other things. We might see people reaching for an object and, never getting it, trying to sit down on a chair and kind of missing the edge. And there might also be misinterpretation. So seeing things like their self in the mirror and not recognizing oneself, thinking it must be somebody else there. So depending on, what exactly the issue is, it's a lot of environmental adjustments. So, covering the mirror, removing mats, patterns, being really mindful of lighting, trying to minimize shadows in the room that might be misinterpreted as something else. And we can really use contrast to draw attention when needed. So if we think of something like the bathroom, everything's often, all white, the floors, the walls, the toilet, the seat. And so the person living with dementia might make their way to the bathroom, but then they're not able to see the toilet because everything just all blends in together. So having a really different colored toilet seat, like a black against that white, provides the contrast that's needed to be able to see. Attention deficits is difficulty maintaining attention or focus on a task. So the person might be really easily distracted, continuously getting up and leaving before finishing their meal or their activity. So it can be helpful to try and minimize distractions as much as possible, offer simple choices, and really go at the person's pace, trying to be creative and flexible in our delivery of care. So, for example, if they can't sit and, have a full sit down meal, can we provide them more, on the go items like a banana, a granola bar, a sandwich, to try and meet their needs in that way? Anosognosia is the inability to recognize that something has changed. So the person really lacks insight into their condition and functional limitations.
Hi, Georgie.
Oh,
Georgie.
we just hear someone. Do you have a question or? Okay. So we say here, that they don't know that they don't know. So perhaps, I don't need any help. There's nothing wrong with me. I've already showered perfectly fine. And so when it comes to this anosognosia and, care refusal that often accompanies it, we really have to try and gain the person's trust, listen, validate their emotions, and start with, more pleasurable activities and build our way towards the care task using knowledge of their, personhood. So what do they like? What do they not like? How can we use bits of their past to really be creative here? So things like, saying you want a spa package, we're going to go get our hair done at the spa today, or, you got a coupon, we don't want to waste that, it's about to expire. Just different ways that we can get people more inclined or, more likely to want to do these different care tasks with us because they're more fun, they're more pleasurable. And then apathy. So that's a loss of ability to initiate or engage in an activity. So the person often appears just uninterested, detached, and there's really a lack of motivation. And so it can be hard to distinguish apathy from depression. Um, but typically with depression, there's going to be that mood aspect, whereas with apathy, there isn't. So someone who's depressed, they might not want to get out of bed because of that low mood or the lack of interest in doing things. Versus with the person with apathy, it's not necessarily a low mood or a lack of interest. They're just very indifferent. They're passive. I could get up, I could not. It doesn't really matter either way. But when they are engaged in something, they do enjoy it and they do have fun. There's just not that motivation to get things started. So someone who's experiencing apathy really relies on others to be the starter button, be that motivation to get them started with things, and then hopefully they'll be able to continue on with the task. So those were all our cognitive symptoms of dementia, our 8 A's. So looking now at the behavioral and psychological symptoms of dementia, which usually we refer to as BPSD. And there's many different categories of BPSD and different types that fall under each. And BPSD is quite common. Over 90% of people living with dementia are going to experience at least one kind of BPSD at some point or another in their journey. They tend to be more frequent when we get to more advanced dementias. Usually anxiety and depression are among some of the first symptoms that we might see. And things like agitation, irritability, aggression, disinhibition typically occur more in later stages of the disease. And for the person living with dementia experiencing BPSD, they tend to have poor mental health, a more rapid decline of both their cognition and their physical health. There tends to be much earlier admission to long-term care for people experiencing BPSD, which is certainly a real challenge right now, and higher mortality rates as well, either as a direct result of the behavior itself, perhaps wandering outside in the winter, inappropriately dressed, or it could be, related to medication side effects that we're using to try and treat these different behaviors. There's also an impact on the caregivers. There's increased caregiver burden, trying to deal with the different behaviors, decreased quality of life and mental health for the caregiver, as well as an increased cost of, trying to care for the individual with dementia, either having to bring in, extra support services into the home, or looking at retirement home costs. And so why do we see changes in behavior? They're really a way of the person communicating something with us. They have some kind of need, discomfort, feeling, and they're not able to communicate that with us in the way that they normally used to. And so as a result, we see, the yelling, the restlessness, the trying to hit or kick, but they're really responding to something in their environment. And so for us to try and address the behavior, we have to try and figure out what that underlying trigger might be for the behavior. And we always come back to the saying that all behavior has meaning. And so this iceberg is a really nice example of that, how what we see is often just the tip of the iceberg, the calling out, the restlessness, the yelling, versus the reason behind the behavior occurring. There's so many things that might be happening, pain, fear, the different A's that we just talked about, medical issues, things as well as just boredom, loneliness. There's nothing else to do. So we start seeing behaviors. And so when we look at, reasons for responsive behaviors occurring, we can try and group them into these different categories, which we're going to look through a little bit more closely. So starting with physical health, we want to see, the 5 Ds. Is there some kind of disease that's impacting this person? Something like a UTI, constipation, urinary retention, all could be causing, this person to display a behavior. Looking at drugs, has there been any changes in their medications, things, added, taken away, dose changes? Is there a discomfort? So are they, in pain? Are they hungry? Are they just restless, need to move their body, reposition, and they're not able to do that on their own? Looking at vision, hearing, again, mobility, like I mentioned, as well as considering delirium, which really is a medical priority and something that we need to address right away. Considering emotional factors, so if the person has a mental health history, so we do see that, someone who perhaps has anxiety throughout their life, if they develop dementia, it tends to be, even more heightened throughout that dementia journey. So that's something we can be aware of. Looking at history of trauma, those trauma memories tend to hang on some of the longest with us. So that could be impacting behavioral responses that we see. Looking at psychosis, and so we're going to look at some different signs of psychosis. Substance use as well is really key here if the person's using substances and how that can impact the behaviors that we see. Again, cognitively, all those 8 A's might be impacting the person and the behavior. Like I mentioned, that aphasia, loss of language, they're not able to communicate with us like they used to. And so as a result, we get a behavioral response. Functionally, we want to consider any strengths that might be underused or abilities that are being overwhelmed. So, if we're asking much of this person, or also if we're taking away and, we're doing too much for them, even if it's very well-meaning, it can be taking away from the person's independence. So we really want to consider, what ADLs, IADLs they can do, how we can support them with that. And looking at how the environment is set up. Would a change in environment assist with the behavior that we're seeing? Because sometimes the person might just need more supports around. And so coming to that environment, is it really enabling or disabling the person? We want to consider things like noise, their routine, is it similar to what they've been used to all their life? Or are we trying to wake them up, extra early, or trying to, put the person to bed much earlier than they are used to? Wayfinding signs are also really key as well, things like how to just find the washroom, and making sure that there's opportunities in the environment for all types of stimulation, cognitive, physical, as well as social, just opportunities to get together and engage with each other. And considering, the actions of others in the environment and coming back to that verbal versus nonverbal communication, really less than about 10% of our communication is the words that we're actually saying. It's a lot more the body language, the facial expressions, the tone of voice, really how we're saying the message versus the exact words that we're saying. So that's something that, we can be very mindful of when we're speaking and interacting with persons living with dementia and how they're picking up on our expressions. And then boredom, loneliness, lack of success. Those are really key areas that play a role in behavioral responses when the person just really doesn't know what else to do. And really, there's no medications available to treat this boredom, loneliness, lack of success. There isn't a medication that's going to change that behavior. So it's really up to us to consider changing with the environment, meaning more meaningful activities, more things for the person to do so that they are more successful. And so that really brings us to personhood. Who is this person? What do they like? What do they want to do? What are their needs, their interests, their skills? So that we can really tailor activities to the person's preferences, to their culture, their spiritual preferences, their social interests. And so if we're trying to find, what triggered a behavior, we can use ABC charting, which is quite simple. So we're essentially just marking down, what the behavior is, what occurred just before it, so that we can see how that might have influenced the behavior, and then charting if there's any consequence to the behavior. because sometimes it's not really a negative consequence. There's nothing that happens because of this behavioral response. And so there might not be a need to intervene. More detailed version, we can look at the BSO DOS. So with this one, we're really collecting info on the person every 30 minutes for 5 days and making a note of where they are and what they're doing. And then we color code it, which makes it really helpful trying to look for patterns and trends in the data. So in this example here, we can see that every day around 1800, this person starts having, repetitive vocal expressions, repetitive requests. And so if we use this, we might be able to say, well, just prior to 6 o'clock every day is, dinner time, and everyone starts moving to the dining room, and then Mrs. gets very confused and upset about where she should be going, what she should be doing. And so to intervene, with this behavior, if we identify that as the trigger, we can always take Mrs. into the dining room first, get her seated so that she's comfortable, she knows where she's supposed to be, and then we can start shuffling everyone else in behind her. And so this is how behavioral escalation, typically occurs. So we get to know someone at their baseline, something's going to trigger that behavioral response, and we're going to see signs of anxiety starting before we get into verbally protective behaviors and then those physically protective behaviors. And this dotted line here is really reminding us that even after a physically responsive behavior and a person seems to be on that decline recovery, there is always a chance to have another physical behavior. So still being very aware of our surroundings, our personal space, how close we're getting to the individual when we're trying to provide that supportive recovery after there's been a behavior. And so a way that we can try and intervene in that, behavioral escalation so that we don't get to the point of verbally and physically responsive behaviors is with the Vera method, which is really a validation method. So we validate the person's feelings or reality. We're responding to their emotions, not their words. We're reassuring the person, and then we're trying to redirect to a different activity to engage them in and draw their mind off what they were so focused on. So for example, here, Joan comes to you and exclaims, "Someone stole my wallet." So we might start by validating, "I'm so sorry your wallet has gone missing. I would be worried too if I lost my wallet." So we're responding to that emotion. We can reassure her that, thankfully we don't need it right now, but I'm going to do my best to help you find it. And then try and switch to an activity. So perhaps while we're searching for the wallet, we say, "Oh, I found this picture of you. Can you tell me a bit more about it?" And see if that distracts her onto a different train of thought. And if not, perhaps she just gets upset and says, "I don't have time to talk about that. I'm looking for my wallet." Then we can just start again and say, "I'm Joan. I'm so sorry. I know this is really important to you, that you're really upset here. Let me help you keep trying to find it." And we just work through it again. So coming to some different examples of behaviors. Illusions, they aren't really a behavior, but I've included them here because they often get confused with hallucinations and delusions. So an illusion is when we're misinterpreting a real experience. So for example, this coat and hat often look like a person standing in our room in the evening. So we're misinterpreting something that really is there in the environment. Versus a hallucination, it's not a misinterpretation. It's just the brain making up this false perception with no external stimuli. And so we most often have visual hallucinations. So things like, animals, bugs, people. It could be auditory, hearing other voices, hearing music. Or, less common, but they do happen, is, having these false smells, tastes, or touch. Sometimes people feel bugs under their skin, or they feel like someone's, touching their arm. So those are hallucinations. Delusions are these fixed false beliefs that have no basis in reality. And so there's lots of different types of delusions, and then we can classify them as bizarre or non-bizarre. So a bizarre delusion is something that isn't actually possible. So something like saying, I was taken to a UFO last night and now I can hear what other people are saying about me and everyone's gossiping about me. So that would be bizarre because we know it wasn't actually possible that that happened last evening. Versus a non-bizarre delusion, which is quite common in dementia, is this delusion of jealousy that you believe your partner's cheating on you. And so, it technically is possible that a partner could cheat on you, but what makes it a delusion in this case is that there's no evidence or no basis for this belief. And, despite any evidence that the person's shown, kind of on the contrary, they don't believe it and they really maintain that strict belief, whatever that may be. That delusion is really firmly held. And so when we're trying to, help someone who's having a hallucination, we really want to see, is it causing any upset or distress to the person? Because if not, there might not be a need to intervene. If they're just seeing, cats and dogs running around and they think it's lovely, then that's fine. There's nothing that we need to do other than just kind of monitor over time, offer reassurance to them. And we don't want to argue about it, but we don't want to agree, not, saying, oh, I see them too, but not telling the person they're not there. You could just say something like, I don't see that, but I understand it's very real for you, or that you do see or hear that. And so if it is causing distress to the person, we can try and treat them with antipsychotic medications. But for folks living with dementia, there is an increased risk of stroke and death with antipsychotic medications. So that's why we don't just, globally put everyone on them just because they're having a hallucination because of that risk. And for some people, just distraction or a change in environment, just leaving the room and coming back in can be helpful at making the hallucination go away. When it comes to delusions, really confusion and memory loss are big contributing factors in dementia. They're misremembering stories, trying to fill in the details. And so we want to try not to take offense. Again, try not to argue or convince the person otherwise. Antipsychotic medications can be helpful at lessening the delusion, but it can be really tricky to get people to take them because, they really believe there's nothing wrong with me. It's my partner's cheating on me, so why would I take a medication? And so really we want to try and just, give simple answers, switch the focus to something else when we can, and really coming back to using that Vera. So for example, someone says to you that their soup has been poisoned and, we don't want to get into this kind of, yes, it has, no, it hasn't, because the person, they're just going to maintain that belief that it was poisoned. So we want to just validate their emotions. I'm so sorry. I would be really worried too. Let me get you another one or something else instead, and then see if we can distract onto a different topic. Oh, there's music coming today. Do you like to go? What do you like to sing? Tell me about it, that type of thing. Anxiety and agitation, like I mentioned, anxiety is often seen early on in dementia. I mean, really, this person's losing the ability to take in, negotiate new info. And so it's really a direct result of the disease, that fear of trying to make sense of a confusing world. Particularly, if there's a bit of insight into changing condition, that recognition that things aren't quite working the way they used to. Changes in routine and environment can also be very anxiety provoking for the person with dementia. Because again, the world is just not making as much sense as it used to. And so they really thrive on that predictable routine. When it comes to wandering and exit seeking, we know that about 3 out of 5 persons living with dementia will wander, and it could occur at any stage of the disease. And there's no medication that's going to make someone not want to wander. And so really we're trying to find out, that underlying reason. Is there a need that they're trying to fill? Are they restless? Are they bored? Are they looking for someone or something? And so we can try and use, signs, labels to support the person. If they're living at home, we can look at GPS trackers, or we might consider a secure living environment, like a locked memory care unit where the person is able to wander without that risk of exiting the building. When it comes to verbally responsive behaviors, we want to, try not to take things personally as best we can. We often hear that, if the person living with dementia would never say these things, or, they'd be really embarrassed if they knew that they were saying these kinds of things now. So we always just come back to using that VERA, that communication strategy, considering the nonverbal, giving people their personal space to really try and calm down when we're de-escalating the situation. And if we get to physically responsive behaviors, we only ever want to touch someone as a very last resort. We don't want to try and, touch, restrain them, limit their movements. It's much better to just remove other people from the area so that everyone stays safe. Give them that personal space. We say doing nothing can be having a plan. And then when their behavior is over, then we can try and intervene, approach, but still staying from that distance. And so coming back to this again, the unstimulated brain is going to stimulate itself. So when we have boredom, loneliness, lack of success, we have to try and engage the person in meaningful activities. And so there's lots of different activity options that we can try, things like exercise, massage, music therapy, robotic pets, but we always have to come back to the personhood and what the underlying trigger is for the behavior. I like to give the example that, with my personhood, I'm very much an animal lover. Even now, I love our robotic cats and dogs. I think they're very cute. And so perhaps one day, if I have dementia, maybe I'm very restless and it's just because I'm bored or lonely and you give me a robotic pet, I'm probably going to be really happy because you identified that need and you gave me something related to my personhood. But if perhaps the next day, the reason that I'm, anxious or restless is because I have to go to the bathroom and I'm not able to get there on my own, and you come and just plop the dog down in my lap, you're not going to be successful. I'm still going to have the same behavior because there was a different need or a different trigger for the behavior today. So that's why, sometimes what's successful one day isn't successful the next day because perhaps there was a different underlying reason today. So just being mindful of kind of that personhood, the underlying reason, and always just trying again and again. Even if something worked but didn't work, or it works half the time, it's still better than no time. And when it comes to communication, we always want to try and place ourselves in the person's shoes. Remember that, their reality is different from ours, and they're not, attempting to be deliberately difficult or make our day harder. So trying to respond with that kindness, patience. We say connect with the person rather than correct them. Use, positive, supportive communication, verbal and nonverbal, and always remember that VERA for when we're trying to de-escalate situations or redirect someone onto a different wavelength. And that brings me to the end of the presentation. So I will stop sharing, and we have some time for any questions or discussion that you might have.
Well, it was a very interesting conversation, and I'm sure that we are all taken aback with a lot of new information that had been shared. And, I didn't know half of it, more than half of it. And I'm supposed to, in a way. So thank you very much. I just encourage everyone to speak up and to share their thoughts and questions. Well, if there are no questions, then we all thank you very much, Caitlin, for a very insightful and detailed discussion and presentation. if somebody should have any questions, they could reach out to me, and I find a way to. Oh, we have Christine and Louis hand up. Please go ahead.
Hi, my name's Christina. I'm taking this because I volunteer with a group that has folks with dementia in it. And thank you for this. A lot